welcome to PAMED Talks, a podcast brought to you by the Pennsylvania Medical Society. I'm Arvind Cavale, PAMED President, and as part of my presidential initiative, I'm highlighting the intricacies of owning and operating an independent practice. These conversations are designed to elevate physician experiences, challenges, and successes, and to demonstrate how physician autonomy strengthens patient care, patient outcomes, innovation, and the future of our profession. Today, I'm happy to interview Dr. John Pagan. John is very well known throughout the medical society. He is currently the CEO of the Pennsylvania Clinical Network and former speaker, chair of the board, and president of the Bucks County Medical Society. He is a board-certified surgeon practicing in both Bucks and Montgomery counties. Thank you, John, for taking the time to discuss this topic with me.
It's an honor to be with you here, Arvind. It's an honor that Bucks County has a president from our own county. So as a county member, it's nice to see Bucks County in leadership, and it's especially nice to see your initiative and your champion voice for independent practice. I think the Pennsylvania Medical Society always is a strong advocate for independent practice, but as you and I both know, employment trends show that we are the minority in things, and it's important that independent practice and all it takes to be independent is highlighted. So sincerely appreciate your presidency and your initiative and this opportunity to talk.
Great. I think this is a good opportunity because there may be multiple avenues that we can discuss that kind of might actually, in the end, dispel the theory that everybody is going towards corporate medicine or employed medicine. So that's where I think we should eventually find ourselves in by the time we finish this conversation. But before we do that, I want to take a little bit of a history lesson from you as to what was the idea of the PA Clinical Network, and where did it come from, and what was the initial motivation behind this?
I think it's a great question. It's always one, when I speak to docs, both within Pennsylvania and outside of Pennsylvania, to review the unique history of the medical society in this initiative. And over a decade ago, when there was a movement towards more value-based care and more value-based payment, so a shift in the paradigm of payment, and fee-for-service was no longer the only mechanism to be paid, the medical society thought that it was important that doctors understand what value meant, and also not only understand it, be part of that process, because it is an evolution. And absent the doctor's voice in that conversation, we all know what those outcomes, even well-meaning legislators and administrators, will lead down a path which is sometimes then challenging to take care of patients. So the Medical Society thought it was, and it was a blueprint in the House of Delegates. They dedicated an entire meeting to this concept, and it ended up being a paper called Get in the Game, basically where our physicians needed to get into the value-based game, and that the Medical Society committed to giving doctors the tools in order to participate and succeed in value-based medicine. Shortly thereafter, a couple years later, I guess shortly is all relative, but sometimes it feels like an eternity, but the Medical Society then came up with another House of Delegates meeting, which was a committee of the whole, meaning that they dedicated the whole meeting to it, and it was called the Practice Options Initiative, or POI. And it recognized some of the topics that you were talking about, that there was an overwhelming trend towards employed medicine that exceeded, or at least the perception of it, exceeded reality. And that physicians coming out of training felt that there was no other option but to be employed. So the Practice Options Initiative was basically to prove the theory that there are choices, both for physicians and patients. Independent practice is one of those choices. If you chose to be employed in an employed setting, that's wonderful, but that should be a choice, not an obligation, and that you should go into it knowledgeably. And further, even if you're in an employed setting, having the option to leave the employed setting and go into private practice is an important choice to recognize there. So it basically benefits all doctors in that. So that's where the genesis was for the PA Clinical Network, or the Pennsylvania Clinical Network. At the very beginning, we were also called the Care-Centered Collaborative, and you'll hear that name sometimes. And long history lesson, way back anteceding that, the Medical Society had a subsidiary called the PAMED Services Company, or PIMSCO, and that was kind of a mothballed corporate shell where the CCC or the PACN took place. So you'll hear all of those names. De facto, the day-to-day operations of the PA Clinical Network there, which is a value-based initiative, which again is to give doctors the tools to survive in value-based care. Whereas in an independent practice, you may not have ready access to the data and all the other things you need to succeed.
Gotcha. So how is the PA Clinical Network different from other clinical networks, maybe owned by hospitals or other entities?
That distinction that you just said is probably the biggest one, is that we are the only state affiliated or state sponsored clinically integrated network in the country. I did have the privilege at the last AMA meeting to talk to the state coalition of executives there, just to show what Pennsylvania has done. And it's been, again, relatively short, but still it's been a long haul to get to where we are today. And it's certainly not the end of the journey. It's, we're continuing to go on with that. So I think the biggest distinction is exactly that we are sponsored by, or our doctors are, it's Switzerland. It's neutral. It's not a health system. It's not a payer. It's not Wall Street or venture capital.
Correct.
It is your medical society and your advocate that is supporting this.
So those physicians who are not fully aware of the hows and whys of this, what should they learn? Like, what is their lesson, and if they want to get into the game?
I think this is a great question, and there's specifics of the PA Clinical Network and joining that. There are other ways to participate in value-based care and other entities out there. I think the most important lesson is, and I think it's especially for our generation of physicians, which are taught two things. Mainly, we're often taught to be an army of one, that everything is our responsibility, and it's beyond. There are other members of the team, but ultimately, even as a resident, if the blood didn't get drawn or the lab didn't get resulted, it was somehow your fault, and you needed to correct that. So that's one lesson. The other lesson is that we are taught very, very well to take care of problems and issues as they present to us in that. And reactionary maybe is a term to use, but fixing problems rather than preventing problems was not part of the mainstream curriculum years ago. So we have excellent doctors that can take care of problems very, very well. I think the biggest eye-opener in the value-based realm is raising your gaze beyond the exam room to who's not in your exam room, to the people in your community, be they family members, being they part of a health plan, being part of an employer group or whatever, who's not making it into the office and who needs that care. And beyond that, after they've been in your office, what can they or should they be doing to stay healthy before their next office visit?
Gotcha.
I think those are the biggest eye openers in value-based care. The second one is the need to have data. That data doesn't come easy. It comes in aggregate, and taking care of a patient one at a time gets added up into a big aggregate, and that aggregate compared internally and externally. So having access and being able to quantitate the good care that you give every day is the other part of the value-based equation.
Right. So does the clinically integrated network provide physician members of the network the resources and the technology needed to accumulate, first of all, collect and then accumulate and then collate all the information?
That's a great question. It's kind of a softball, but that's kind of one of the things in the blueprint to get in the game, as well as in the Practice Options Initiative. It was recognized that data is often beyond the grasp of a small practice. That data infrastructure, it's hard to accumulate, it's hard to quantitate, and then of course exchanging that. So sharing that data in a larger community, like a clinically integrated network, hence the word integration, the integration of data in there, that you're able to now share that with a group, and then that group's results or data can then be compared to others, and you can now be recognized and rewarded for the great care because now you've quantitated it. I think one of the other generational changes in medicine is, back in the old days, you trusted your doctor and he or she had your best interests in mind, and there wasn't much need to validate or defend that beyond that. But now, and this is not necessarily a bad thing, that's all well and good, doctor, but prove it.
Right.
Show me.
Right.
Show me how you give better care. Show me how I'm being cared for better in that, and that's where the data comes in.
So the reason for my softball question was sort of a hardball follow-up is you know that I'm an endocrinologist, and I'm sort of like produce and consume data, or consume and produce data, whichever direction tremendously. I've been data dense for 25 years, even before data was even considered part of medical practice. But I'm also of the belief that as clinicians, this is where sort of some of my disagreements come with some of the value-based initiatives, is that I feel data collection processes for physicians is equal to texting while driving. And if we believe that data is equally important as clinical care, then we should really not be in the job of collecting the data. So does the PA Clinical Network make that part of data collection more streamlined for participating physicians?
You're exactly right. This should not be an extra burden, and providing the infrastructure is not, hopefully not, adding tremendous burden to it. And I like your analogy of texting while driving, because it takes your full focus to take care of a patient. You have to listen, and you have to listen not only to the words that are said, but the words that are not said, to the subtle cues and everything in caring in total for a patient. And being absorbed in that does not mean turning your back and clicking on things. So extracting it through the data that you have, and in the network itself, our physicians are truly independent. They're in their communities, serving their patients in the best way that they believe in there. They choose their own EMR, they choose everything else. So this is one of the challenges, is getting a data overlay that's behind the scenes extracts data without imposing or burdening on the physicians. Now, one thing that does become obvious in the process is in the binary world that we live in of ones and zeros, you do need to code fully and you do need to code properly. So just giving good care and not necessarily reflecting it in your documentation somehow is not gaining you the full recognition that you need. So that is one of the things that does come back and is one of the learning points. And even the docs in our network that said, I thought I was doing it really good, but now, with this extra support or these reminders, I realized that,
right.
I wasn't doing it fully. So coding fully and completely capturing a patient is an art, but it also is a checking the box too.
It's a practice too. So my idea is having an umbrella organization, connecting the different docs in the different areas, could potentially be both a sharing type of organization as well as a supporting kind of organization, in terms of actual process. We don't want doctors clicking boxes, and so it's not just the manual function of clicking boxes, but it's also the thought process of, did I click all the boxes today? To make sure that I documented all my, high quality work. I think that might be also the added value of a learning type of network, that somebody else is doing it better. How can the network bring that process, that best practice to another practice?
It's a good point, and as well as I do, sometimes we learn best, or we're hear best from our peers.
Correct.
So when we do, and in the network we do this, especially in the ACO, we'll highlight, every month a physician, what they're doing well, how they're doing it, and it's really just very candid discussions. This is what I thought, this is what I learned, and people do learn by it. So yes, supporting them in that and giving them the tools in that network are what we're about. And we altruistically and hopefully we do want to restore some of the joy of medicine.
Yeah.
Because being independent in and of itself is a joy. No doubt about it. It is hard. There is nobody that knows the ins and outs, the challenges as well as the joys, better than an independent physician, because every day in real time that physician is encompassing all that it takes to provide care. Correct. Including the building and the infrastructure and the staff and the payroll and the insurance and both health insurance and liability insurance. So all of those things are wrapped up in present time in the independent doctor. And again, nothing against the university setting or the large health system, but those things are departmented off and are one or two steps removed. So if there's high liability premiums, you're still getting your paycheck, but eventually it's going to affect your care and the care you're able to deliver.
Yeah. So when I was thinking about my presidential initiative, I sort of went back to the past 3 presidents and the few things that you've just said. And so Dr. Lucas Pham was talking about practice options, and Dr. Kristen Sandell was talking about joy in medicine, and Dr. Wilson Jackson was talking about physician leadership. It's interesting that if we look back at the PA Clinical Network, through that clinical network, we can probably demonstrate all 3 activities, right? So you just mentioned joy of medicine, you mentioned choices, practice choices, as well as leadership, right? So creating the network can provide significant leadership in terms of sister societies, even the AMA for that matter. What's your
I'll take it a step further, and I love the way that you've approached your initiative, you've approached the presidency, maintaining historical context, because none of us are a silo or an island that we are on the shoulders of the people that came before us, and doing it and connecting all the dots or the docs is important in that. So So one of the lessons that you see continuously bear out in the literature, especially in terms of value-based care, is the physician-led organizations tend to do better. They tend to do better there because the physicians have inherent in that, and that is like baked into the DNA, obviously, of the medical society, as well as in the clinical network. So physician leadership and physician governance. So all of our committees are populated by our own physicians. We actually compensate. We pay for time. It's not career-changing wealth, but we acknowledge that your time is worth something. Whereas a lot of times in the university and the other settings, it's just expected that you do X or Y in terms of doing that. So yes, the physicians, and this also goes back historically to the blueprint, which again, the physicians need to be part of that game. They need to participate and they need to lead that change. Otherwise, they're going to be subjected to the changes on the tail end of things. So getting involved and understanding really what it makes and what it doesn't. And we can be very, very honest that some of the things that are called value, and I think this is maybe what you were talking about before, because it could become administratively burdensome, are not necessarily value. That there are surrogates for value. There are quality check boxes and things that make sense, but may not directly correlate with actually living a healthier or longer or a more happy life in terms of doing that. I think one of the most frustrating things in value-based medicine is the concept of the performance year, which often coincides with the calendar year, begins on January 1st, ends on December 31st, and then suddenly, the same patients you've been taking care of for your whole life, on January 2nd, they now have no diagnoses, and you now have to start all over again, and you have to do that. So that's some of the frustrations as people try to get their arms around what is quality. You do get these intermediaries in there, and again, we try to make that as least burdensome as possible. But
that actually brings a sort of a quirky question: is how do you prepare your physicians for that kind of a little bit of a hiccup based on these technicalities? Like, would they say, "Oh, I did everything great last year, and now all of a sudden I'm not getting the score for it"?
Oh, you got to get the score all over it. You got to re-earn it every year. Now the good thing is that you're always delivering good care. The question is capturing that and recording that. So with good care, that's the hardest part. And we're blessed in the network to have a group of doctors who deliver good care. So it's not like you're teaching them how to give good care. You're teaching them how to get recognized for the good care that they're already doing,
and make it as natural as possible,
and helping them that. And so, what the network does is we have, our staff has reminders for the doctor's staff, and again, trying to not burden those that are giving care as much as possible, but pre-huddle, like before a patient is coming in or before that week's patients, so-and-so is going to come in. These are the things to watch for, because as we both know, in the heat of battle, not that it's a battle, but when a patient comes in and unloads, and all of a sudden there's 3 things that weren't on your list, and some of them are actually maybe more acute or serious, it's easy to forget about the colonoscopy that was due last year, or the mammogram, or the other quality indicators that are in there. So having a pre-game plan, I think, is important, helps relieve that burden. And we have a post-game support too, that hey, it looks like you did everything, but this could have been coded. And we do have coding experts in the background working as well. So those kind of supports, again, hoping to do it, and working whenever we can without the doc himself or herself, but with the staff.
Gotcha. So a couple of technical questions, let's say. So how does a doc or a practice get into this network? Is there an application process? Do you need to be
Yeah,
a certain type of practice?
there is a two-sided evaluation that goes on. That if someone expresses an interest, we explain what the network is and what it does and what it doesn't do. One thing that the stage that we're at right now, we do not negotiate your baseline contract. So whatever your contract is with Aetna or Capital Blue Cross or Independence Blue Cross or Humana or UPMC or Geisinger, whatever your contract is, it is. We are the value layer on top of that. So explaining exactly what, hopefully, level setting expectations, this is what we can do, this is what we can't do, is helpful for both sides of things. Our quality team often will ask for prior quality scores to try to get an understanding of what it is. It's not for everyone, and we've learned over time in the years, since our formative years, basically, we came together and we learned along the way. But, now we do show a mirror to a practice, and the main thing is having some bandwidth to communicate back and forth. That this is what it means to be in the network. These are the patients that can get you to the next level of recognition, and thereby the whole network to the next level of recognition. If you don't have the time, the energy, or the staff to pick up the phone or answer the email, it may not be a good fit, because in an integrated network, communication has to flow both ways, and if you don't have the time or the energy to do that, that's it. So learning about the organization and learning about the group, there is a due structure which is highly favorable towards PAMED members. So you don't have to be a member to be a member of the PA Clinical Network.
Gotcha.
However, you will pay far more than your dues in being a non-member. So we have almost 100% membership because it makes sense to be a member in there. So there is dues in that. And then there are some obligatory, federal as well as state and insurance requirements that, if you're going to participate in a clinically integrated network, this is what it means and this and that. And it's, some of it is like you're committed to the patients, and even if you drop out of the network, you still may be responsible for sharing data, supplying data, and things like that. So there's not an application per se, but there is a getting to know each other, and we take a good look, because if it's not a good fit, it doesn't work for you, it doesn't work for the rest of the docs in the network either. And there is a credentialing process too, just like any credentialing. We'll go over, NCDB, and other credentialing things, and have a committee, again, physician-led and staff, that goes over and approves or doesn't approve credentials and renewals.
Okay. So is there an opportunity for a practice that has never been part of a value-based contract to be part of it? And second part is, if some practices don't participate in certain insurance networks, would they still be able to participate in?
Right. We try to provide a menu, again, because we don't own any practice. We don't dictate. One of the advantages, you said, what's the advantage of your network, is we're not authoritarian. We're not, this is not your hospital system saying, thou shalt do this and thou shalt do that. No. You decide the best way to take care of your patients. Obviously, geographically, there are going to be different insurers and different opportunities in different areas of the state. This is a statewide clinically integrated network. We go all the way from,
Erie
to Scranton and every place in between. So we have little communities everywhere, and not every insurance product is available everywhere. Where we have a value-based contract, you're encouraged to join it. If you say, I'd rather not, and in most cases it doesn't make sense not to, because this isn't a value overlay. This is an add-on in terms of reimbursement in addition to your fee-for-service to do that. Sometimes physicians will, in certain contracts, especially when it comes to Medicaid, some of them require having an open panel, and some of them don't have the staffing or the wherewithal to have a completely open panel for Medicaid, so they'll say, no, I'd rather not participate in that. One of our newest initiatives is the ACO, which is CMS and the Medicare Shared Savings Program there too, which is again is an opportunity there. There are some practices in our network that before we got together were doing something else in that sphere. So they can, if they choose, they can continue to do that. If they want to come to us, that's fine too. So long-winded answer to your question, you figure out what fits best for you.
But there's no mandate.
Obviously, the more value-based programs you participate in, the more financial sense it makes in that, because there is monthly dues, or you could pay annually for a discount in the network. But adding your medical society dues to the PA Clinical Network dues, our history so far is about a 14-to-1 or 14 plus ROI. So you'll get 14 times back what you're paying in dues. The more contracts you participate in, the more it makes sense.
Correct. Okay. And is there any opportunity for specialists to join, or do you have only primary care networks?
We do have specialists. The specialists, because of the nature of a lot of these value-based contracts, they are very primary care centric. So there are specialists, and the specialists do sometimes get disbursements, because all of us, even simple surgeons sometimes do some primary care. Not that we intend to, but sometimes you'll end up on a roster as being a patient's physician.
Correct.
And you may be attributed on that roster for it. So it is. But there are opportunities, and some of the opportunities. So we have kind of an affiliate status. If you're not directly involved in a value-based contract, you can be an affiliate member. A lot of our specialists do fall into that category. Being a member as an affiliate benefits the network, because now we can circulate your name, and if we need an endocrine consultant, if we need ophthalmology, if we need rheumatology or allergy, we have people within the network that we can recommend in terms of doing that. But also being a member then gives you the member benefits, which some of them actually are not insignificant. So liability insurance, we do have a good relationship with liability insurers, and can usually do better than what you're doing on your own. And now our newest thing is health insurance, that we often can help in health insurance as well, and figure out an arrangement, which is like an irony of ironies, that we as physicians have to struggle to get health insurance for our staffs and our own families.
Correct.
In that.
That is the biggest irony, actually.
Yeah.
Yeah. So one of the things that, while you were talking, kind of came to my mind is, you have an advanced business degree as well. So from a business standpoint, where do you think the opportunity for growth for the integrated network can be, in terms of looking outside the box?
Well, there's
if you had your choice.
Right. So there's in the box and outside the box. So I don't think we've saturated in the box yet. That there are surprising numbers of independent doctors in no value-based arrangements at all right now still. So there is a field right there that is not fully penetrated in that. The other I think potential alignment is now outside, and again, having spoken at the AMA and realized no other medical society is doing that. Now, are there value-based arrangements in every other 50 states? Sure there are. And maybe they're aligned with a system, maybe they're aligned with a payer, maybe they're aligned with a for-profit venture. But I think those societies have a market advantage, being Switzerland, being neutral, being advocates for their docs, and we can work with other medical societies, or just consult with them and say, listen, if they want to join with us, that's fine. If they just want our advice, that's fine too. There are some painful lessons that we've learned along the way, in doing this, and there's no need that anybody else reinvent the wheel.
Correct. So what I was thinking about is, You mentioned that there are certain, items that you have to follow, the rules of the road, so to speak, in order to achieve those value-based earnings. Those were all rules that, as physicians, we never got to actually set. Those rules were set by somebody else, and we are now kind of, I wouldn't say forced to, but somewhat obligated to abide by. So what if we had the chance, the opportunity to actually create a new set of rules that allow us to say, as a physician, this is what I believe creates value for my patients, for my community, for the purchasers of healthcare. And if the CIN gets an opportunity to partake or to partner with other organizations who think similarly and say, okay, let's create a parallel value-based system that reinvents the rules of value. How is the appetite for the CIN to look into those kind of opportunities?
This is a journey, and like I said, this is one way that one state has done this.
If you get the opportunity to rewrite the rules, let's say.
Right. So, and what I'm saying is we are learning and we are open and there. I think all of these things, and especially maybe the ACO and certainly some of the contracts with the payers, you get into the concept of total cost of care, right? So, I mean, like it or not, we don't get to rewrite that as physicians. Whether your hemoglobin A1C is
right,
less than 9 or less than 8.5 or is it the last one for the year or is it the average of the ones for the, we get to rewrite those rules, and I think we can rewrite those well. The cost of medicine we don't get to rewrite. However, being in private practice in and of itself, you almost already have an advantage because the health systems have a lot of other expenses that they need to pay for in their large system, and hence the cardiac echo, the CBC, the MRI, the CAT scan is often a multiple of the expense that it takes for an independent doctor to do it. So in the cost equation, the physicians, if networked together or network of networks, aligned people coming together, could do very well. And what are you learning in the process? We talked about the surrogates for quality and things like that. You're learning how to take care of populations of patients. We talked at the very beginning too about not only the patients in the room, but the patients out of the room in terms of doing it. If you can assess the risk of your population and manage that or understand it, understand who your more complex players are that need more attention, that need the telehealth visit, that need the other enablers that are beyond medicine, the determinants that are non-clinical. The social determinants, the transportation, the food security, all those other things that are not necessarily medical off the bat. But in understanding, taking care of that whole population, yes, you can do it. And who do you have value to then? You have value to anybody that has a group of people that need health care.
Right.
A school system, an employer, or anything else like that. So I think our docs and we as a network are learning how to be successful in that dynamic, how to enter into the total cost of care discussion and care effectively and efficiently for patients in that. And part of that is scaling, part of that is numbers, part of that is aggregate, and we have those conversations and will have those conversations ongoing. We're looking for that, and there's nobody that the PA Clinical Network is aligned with that is not mission aligned. Whether it's the liability insurer, the health insurer, the group purchaser, all of them have the same common interest in the physician-patient relationship and making it easier for the doctor. And like-minded groups, likewise, we we do ourselves a disservice to not talk with them.
Yeah. So as you know, we are having our first Independent Practice Summit in Harrisburg on June 19th, and I see that the PA Clinical Network is one of the sponsors. What do you intend to present to the attendees of the summit that will kind of pull together all your ideas, or all your experiences of the past, the current situation, and where the puck is headed to? How do you envision talking to the attendees over there?
Well, I compliment you for the initiative, because I know that's part of your initiative in the summit of doing that. So just convening like minds is helpful. Sharing the story is helpful, because I think hopefully this podcast and other discussions will shine some more light on, hey, I didn't know I don't have to be totally alone. That as an independent doctor, I can join this group. It doesn't make me fire anybody. It doesn't make me hire anybody. It doesn't make me change my corporate structure and to do that. So I think to tell the story and to be at the table at the summit as one example, I'm not saying that we are the be all and end all and this is how it should be done. By no means. This is just how we do it. And I know that in the medical society, there's an independent physician section. Obviously, even within that, there's many different voices. There's people that, different ways to deliver care, different examples of that. I can't say one is completely right and one is completely wrong. I think especially because all of them are aligned with the independent spirit. That's the same mission.
Right.
And
right.
people are figuring out how to do it
Right.
in terms of doing that. Dr. Lucas Femu had alluded to, it's very curious, and sometimes it's love-hate relationship with money,
Correct.
with financial backers, with venture capital, with people that are trying to also improve U.S. healthcare and willing to put their money behind it. Obviously, they have an expectation of return too, so it's not free money, but even those conversations need to take place as well. Yeah. because we're not going to solve this on our own. Although we're educated as an army of one, we cannot solve this by ourselves. And I think, current generation, looking at generation of physician and physician education in terms of health, staying healthy, in terms of working as a team, in terms of all the different people that it takes to do that. We cannot, although we like to think we can do it all, we can't do it all as physicians.
That's true. So you heard me speak at my inaugural. The two sort of philosophical ideas that I try to remind myself of and try to remind my colleagues are gratitude for being in the profession of healing and the sense of optimism. Right? So how does the clinical network sort of exemplify these two ideas, the gratitude of being a physician and the optimism of independent practice? If I were a fourth-year medical student or a second-year resident or so, what message can I get from the independent network?
I think the controlling your own destiny one is important. And I think you talk about, in our profession, burnout, frustration. A lot of times that becomes basically a lack of control. That despite all your years of education, despite all your knowledge, you no longer have control even of your day-to-day schedule. That you can't spend, or you don't feel like you can spend the extra 15 minutes with Mrs. Jones, who really needs it at this time, and you can't, forego this or do that. And it also goes with your family, work, and life balance and harmony and being able to do that. So I think the biggest advantage for the independent doctors, and the reason that most of our doctors are so wonderfully independent, and is because this is what they need to control their lives and care for their patients as best as they can. And they do it in the communities where the patients want it to be. It's not driving to a big center. It's not doing this and doing that. It's going to the same place where, medical care often has been provided in a town there. So I think that's where the joy and the hope of the profession lies, is in that independence, in the ability to take control of your own destiny and your own practice, and to make the best out of it. I have a son in medical school. My wife's a physician. We can't paint an overly rosy picture, but you are answering one of the highest callings that there is in caring for other people. There is no other profession that will give you that reward. If that itself doesn't instill you with joy, then it's a hard profession.
Correct.
It's a hard profession.
So what you described was what I believe is professional autonomy, and sort of the independent practice does bring the stability of professional autonomy to the picture, right? So the other part of my belief is that our professional autonomy results directly in better patient outcomes. How do you see the integrated network sort of promoting or stabilizing or strengthening that concept of physician autonomy leading to better patient outcomes?
So you have two things there. So the first thing I think is exactly the mission is independent practice, or even the medical society's mission of the Practice Options Initiative is like, wherever you think is best to practice, you should choose that setting and to do that. I do believe that done right, that is probably one of the best places to give and to get care. That the physician able to make that decision in the best interest of that specific patient, but also in the context of the whole, is one of the best places to do it. Not necessarily be mashed into a cookie cutter, and everyone that presents with this diagnosis gets this, doesn't get that, gets this amount of time, doesn't get this, doesn't get. You make the judgment. You make the judgment on behalf of your patient to do that, and I think that's what the network is all about, is having your control and your autonomy to decide what's best.
Is there any option in the network where physicians are assisted in planning for succession or transferring their practice? If there is let's say a 2-physician practice or a 3-physician practice, is there any support in the network for that?
We don't have anything formal for that, but we do end up being that, and we don't mind that. In fact, one of our board retreats a couple years ago, one of the breakout discussion group topics was, we want to be the first call. So it doesn't matter what it is. If a doc has a question, we'll take the first call. And with the backing and the support of the medical society, we can help get answers. We can redirect questions and things like that. So we don't mind being that, and we do end up being that. And we've had some unfortunate tragedies. We've had there are just like in a patient life, in a doctor's life, and in the network, there have been a couple of unexpected deaths.
Correct. That is a reality.
That is
practice.
Part of life, right? So we then have a practice manager or a wife who was involved in the practice calling us and saying, I don't know what to do. So we have, being part of a greater whole as a network, we found other doctors to see those patients that were we've given choices, we've given advice, things like that. One of the Dare to Dream things would be, could the network be, a possible employer to those who want that? So you don't want to go to a big system, but you wouldn't mind offloading, or with economies of scale, having to do that. I would love to do that, but we're not there yet.
We're not there yet.
We're not there yet. But I would love to have that as an option, and that could be a transition, even for somebody straight out of school. You could say, listen, come work for us.
Correct.
We'll get you on your feet, and then when you're ready, you break away.
Exactly. No, it doesn't hurt to dream, right? Because I think if you don't dream, you'll never imagine what the possibilities are, right? So that's very important. Couple of sort of hypothetical or philosophical questions, right? So one of the parts of the initiative that I'm working on is to help build a Pennsylvania community-owned health plan. The best way to explain this is to say that it's a grassroots development of a plan that involves PAMED member physicians working directly with their local community employers or school districts or unions, and contracting directly for their services as so-called tier 1 services, where the employer pays for their care directly and the employees have no out-of-pocket costs for seeing these physicians, right? So my feeling is that the CIN, or the Clinical Integrated Network, is a perfect sort of a platform to build off of. And again, this is my sort of pie in the sky theory, but it's not so much pie in the sky actually, because you already have some infrastructure. Right. So how do you want to elaborate on that?
I think you're exactly right. And I think this is where we're going. You know, again, we talked about learning how to manage populations, learning how to manage risk, whether it's an employer or something else like doing that. The you know, without being fairy tale rose-colored glasses, you know, yeah, this is a great start. This is a great start, but it's not the complete picture. Obviously, we would need to fill in the gaps either with specialists or something else like that. Now, we do have affiliations and contacts with specialty organizations that are doing similar things too, and could coalesce and do that. You know, with one of those organizations, and I'll just mention them, TPIN, that you may have heard of in this area.
Yes.
TPIN and the PA Clinical Network actually went to the state. We went in Harrisburg. We met with the state employee there and offered exactly what you said.
Correct.
We would need to probably engage a third party in that as well, administratively and otherwise. But as you said before, dare to dream.
You will meet some of those third parties at our summit in June.
Yeah.
Several of them. So which would be a great connector at that point, right? So that's sort of my dream of how physicians actually achieve their full autonomy, full independence, and actually can deliver the care that they know best how to, right? So the one thing that I've always had problems with our medical education is we never, almost never I should say, think of the needs of the other side, the receiving side, or whoever is bearing the cost of care. We're always focused on how we deliver, what tools we have in our kit, which is not a wrong thing to do. But what I have heard from the other side is the doctors are not at the table, and employers are really suffering. Employees are suffering because the out-of-pocket costs are going higher, the premium costs are going higher. Historically, insurance was based on either higher out-of-pocket costs and lower premiums, or vice versa. Now, that's not a choice anymore. Premiums are going up while out-of-pocket costs are going up as well, which sort of doesn't match the expectations. So the employers are actually looking to independent physicians to say, can we do something to lower these costs? Can we improve access to care in the local communities? I think that may be a really great opportunity for an organization that already has a very solid setup, like the CIN. Would that be an interest?
I couldn't agree more. No, I think that's it, and figuring that out. And you know, while we did not, obviously didn't get a state contract from the state of Pennsylvania.
Correct.
That doesn't mean we don't get up to bat and swing again or try again.
But maybe a smaller group, right? Maybe
a smaller group, a different area. You know, there's different ways to do it, and no, we and obviously it's a board and physician-run thing, but I think our group is eager to show what we've done so far, but eager to take it to the next level as well.
Yeah. So I'm going to go back to where I first started in this whole journey, is to look at, we are always looking to heal our patients and so on and so forth. But I also felt like our profession was ailing as well, and we needed to heal our profession. And one of the tools, I feel, is something like what you're doing, is to bring options to physicians to actually say, it's not all gloom and doom going forward. There is some optimism. There is hope to actually be for tomorrow to be better than yesterday. Where do you place the CIN in that frame?
Oh yeah, I think we are an enabler or a pathway to a better tomorrow. You look at the alternative, and again, the soul of the profession, I think a lot of times is cradled by independent practice.
Yeah.
And if independent practice, let's take the converse of your theory, and you're like, well, it is all doom and gloom, just give it up. Oh my goodness. Can you imagine the landscape then, where there is no other choice?
Correct.
Could you imagine what the profession of medicine would be? Because then it's not really the independent physician, it's the entity that is deciding what medicine is, deciding what professionalism is. We're just deciding what it is, and the entity in and of itself is admirable, but they're doing much more than what the physician, is in doing that, and in that is several steps removed from what medicine started as and at the core is.
Yeah, I would not want to imagine that situation.
Right. So yes. No, number one, it's not all doom and gloom. You can be in control of your own future, and we probably have a lot more power than we think, and can provide direct care in a lot of situations to a lot of employers. Let's not again fool ourselves. It's not total care.
Correct.
Because we are going to need to, there's a lot of layers of insurance and stop loss and, things like that if we're going to start talking about risk and assuming risk for a population. But we do have the basis or the infrastructure to enter into those conversations and to do something nice.
Yeah. So the PACN actually has the infrastructure to deliver on some of those.
And we're a statewide integrated network. I mean, at least within the state of Pennsylvania, we're there. Now, do we have geographic concentration and depth in every aspect of it? No, we don't. And that's where the collaboration, the cooperation,
so
like you said,
how can we help the PACN become more of a player, bigger, more outreach and stuff like that? What can I do to help you?
Well, I think a lot of your initiatives dovetail exactly what we're doing. I think just being mindful of independent practice, because even if you're not in the network and you're independent, I think that is helping that, because again, the lens of the independent doctor is unique in this. I think, where appropriate, that's great. I think as, a state president, you get to interact with other states too. I welcome, and we welcome introductions to our neighboring states or other, it's these conversations and the repetition of the conversations that people are like, what, Pennsylvania's trying something. Let's look into that. Kind of thing.
So in conclusion, is there something that you'd like to tell our viewers about PACN?
I think our whole conversation has actually been a great thing. And just to summarize it, that yes, there is a choice, that you can be independent. Not only can you survive, but often you can thrive in that environment, in that this is a step on the journey. It's not the end. There's more to come. We'd love to be more and do more, as we hear from doctors. And again, as we get into, your ideas about health insurance are exactly where we are too. That one of our options is to be part of insuring ourselves.
Correct.
In doing that and taking care of ourselves in that and expanding that network. And in the model that we're setting up, you can get paid more taking care of within the network than other patients. But yeah.
Cool. I think that was a nice conversation. I really appreciate you coming today, and everything we talked about added a lot of layers to the understanding of this clinically integrated network, added more color. I think hopefully we brought some more people into thinking that they can join this network and sort of build a future, a newer and a different future together. So thank you for coming today.
Sincere appreciation for the invitation. Again, honored to be asked to come here. Honored that we have a Bucks County president of the Medical Society and an independent doc who's out there, as a champion for it. So likewise, it's great. And I also have learned, you have a wonderful historic and contextual approach to things that's how you build networks. It's not all about me, it's about us.
Correct. No, I think we are on the path to healing the healers, I would think. Right? I think that's sort of where I see the PA clinical network coming into play, is to say, let's build a new bridge to a new future.
I like that.
Thank you. Thank you for coming.